Good morning. If people that are outside also please come in and have a seat. Thank you very much for attending this meeting and staying on for the second day. A few people have left, but still there's pretty good attendance, and we were really pleased with our first day. And I'm just going to go over just a little bit of an outline just to bring everyone on the same page. A few people were in and out and requested we just go over. So we talked a variety of areas. We went through 4 topics of first session on the perspectives of hereditary susceptibility to cancer, registries, universal screening, opportunities, variants of uncertain significance, Lynch syndrome testing approaches, and healthcare delivery. Healthcare delivery approaches was the part 1, and today we're going to continue with that implementation and evaluation that part right after I finish. So we talked about challenges to identify in a most efficient manner as many high-risk families as possible. As you all are aware of, this is part of the Cancer Moonshot, one of the recommendations in the Blue Ribbon Panel for prevention and screening of high-risk cancers, and focusing Lynch syndrome as a demonstration project, but we want you to actually think about all high-risk cancers, and similar challenges and issues are in the other high-risk cancers also. So we are going to expand our thinking and ideas that are taken, lessons that we learned from Lynch syndrome demonstration project to the other high-risk cancers also. So there were data that was discussed that suggests that colorectal cancer screening and chemoprevention approaches, John Burns' aspirin trial and vaccine approaches that are in development are beneficial for colorectal cancer prevention, especially in the Lynch syndrome setting. So, but most guidelines do recommend universal testing, although there is additional research is needed to identify reasons for poor implementation, and that's where but NCI can think of research questions and the ideas for how to improve that implementation. Ohio State discussed their data suggesting that universal testing is possible at the population level. However, variants of uncertain significance is a big concern. Ethical, legal issues are significant hurdles as well, and variants of uncertain significance were reported as high as 42% in some cases. Ontario experience of reflex testing for Lynch syndrome cancers Lynch syndrome as a recommended standard of care seems to be working. Cancer family registries presented their data with the mismatch repair mutations, maybe even a higher than previously reported 1 in 280 overall, any mismatch repair mutation in general population. So harms of screening were also discussed. Quality is important, and so it is important to keep it is evidence-based. Aspirin chemoprevention, as I said earlier, were discussed by the CAP trial, but also data from the people in the Cancer Family Registry also suggest aspirin's benefit in the Lynch syndrome. So implementation of many of these evidence-based beneficial testing is lacking, so not enough genetic counselors in the system. That was pointed out, the need for a national infrastructure and consortium for screening and prevention trials down the road once we have enough Lynch syndrome carriers diagnosed. So that kind of brings us to today's session 4, continuing with the healthcare delivery approaches to development, implementation, and evaluation. And today, our moderator is going to be Erica sitting right here, Erica Breslow, her Program Director from Health Systems and Intervention Research Branch, Healthcare Delivery Research Program from Division of Cancer Control Population Sciences, DCCPS, NCI. So she's going to introduce herself and the rest of the group here. Erica.